can tell Alex is no nonsense. He's Russian.
Okay. Decreased fine motor skills.
So 70 years old, Dr. Shupak?
Yeah, I think 65.
So this is your first case, so we'll get you in the scrolling mode. Now you can reach up here and pull series down. I'll just explain to them some things they can do. You can hit your keyboard. I like to hit 3. That gives me 3 up. 4 up, they get a little too small for me. So 3 up will just allow you to get oriented here. And then you can start pulling down what you want, you know. You can pull down your official sagittal. These are just scouts. You know, I like to pull up a flare. And you know, like another projection, maybe a coronal. My coronal is it's like a T1. These are 5 millimeter 2D cuts. It's actually a T1 flare. So I've got a T1 flare. I'm going to blow that up while you guys are getting oriented. And I'm going to blow up my standard water suppression flare, my so-called T2 flare. And I've got my sagittal T1, and I'm just going to scroll around a little bit while you guys are getting oriented. And I'm going to pull down my diffusion image just to see if there's any diffusion restriction. It's actually my ADC map. I apologize. There is a diffusion image right here, the black one. It's the third one in. And just to see if there's any diffusion restriction, which would show up as a white area, because water, which normally moves in an isotropic fashion along the course of white matter, doesn't really appear on the diffusion image. And if it gets stuck in the cell, it'll appear as an area bright signal. There's no diffusion restriction. I'll pull up my T2. Even though it's highly unlikely to see anything on the T2 that you're not going to see on the flare, I'll make that a little bigger, and you guys tell me when everybody is up and running. Everybody up and running? So, you know, when you make your diffusion image, the diffusion gradients, which are rapidly turned on and off, the quickly you bring them up and then invert them, the more sensitive your diffusion image. And that's known as the B value. Typically in neuro, you want B values of over 800 to 1,000. In the prostate, you want it over 12 to 1,400. Ideally, 14 to 1,600. So a B0 is nothing more than a fast echoplanar T2 image without any diffusion gradients turned on. And a B1000 means the gradients are turned on and quickly ramped up and then inverted so that you can detect micromolecular losses of motion or stiffness in tissue from diffusion restriction. Okay, let's start going and take over, Dr. Shupak.
Okay, so interesting case where someone has, you know, the usual sort of not very specific history that we're getting, loss of fine motor skills. So we're starting to think of something neurodegenerative. So looking at this, does anybody have any thoughts about it? See any abnormalities?
Heck, a lot of atrophy, that's for sure.
Right.
Yeah, not a brilliant statement, but...
Well, that's right. Now, but it's a statement we often make, meaning you'll see a lot of reports saying, you know, diffuse cerebral atrophy. Okay, so what I try to do at least is whenever I say atrophy, I try to give a pattern of atrophy. Okay, meaning not just say, well, it's kind of diffuse, but parietotemporal, frontoparietal, because these are going to fit in with different diseases. Okay, meaning the reason this scan is being done is they want a prognosis and they want to see is this something that's treatable. Okay, so if we can give them the information that they need to pursue one or another track, they might be able to either tell the family more or, as we're going to see in some of the later cases, really find something treatable. So let's look at the pattern of the atrophy.
I think genetics too matters. You know, people want to know.
Right.
You know, if they've got something that's heredofamilial, you know.
And that's going to turn out to be really important in this case. So you could say, okay, so is it frontoparietal or what is it? Well, actually, it is pretty sort of central. And when I first was looking at this case, I was like, well, there's some atrophy, but it's sort of a strange pattern. Not a lot of frontal parietal temporal, right? Meaning if you're neurodegenerative, first thing you look at is going to be the temporal horns, right? Because that's the most common neurodegenerative would be Alzheimer's, temporal horn, parahippocampal, entorhinal cortex atrophy.
And here's the entorhinal cortex
So
right
not
here.
that bad.
Not that bad. In fact, it's pretty juicy.
Okay, so we're not talking about an Alzheimer's, right? That wrong pattern.
That's a big deal.
Right. Okay. So what are we talking about? So others in that same thing, of which we're going to see some examples, frontotemporal doesn't seem to be fitting with that. We'll look at some diseases.
There's frontal involvement, but it's not
Right.
that
It's
much
not
worse.
primarily the pattern.
Sure.
Now, what you can do is, so I started doing some measurements, started looking around, and I made some phone calls to see about this history. So if you measure the intracaudate and the frontal horn distance, there are some ratios you can use, and also the intercaudate to intertable distance. So the normal ratios there are the frontal horn to intercaudate is 2.2 to 2.6, and the intercaudate to the intertable 0.09 to 0.12, and these are abnormal. So this patient has caudate and basal ganglia atrophy. I think the caudate and putamen are atrophic.
I mean, look at the size of the putamen.
Right.
It's
This
minuscule.
little sliver of a thing, right?
And it also has a little bit of high signal on the flare. You can just barely see it on the T2, but you can see it right here, and that is a sign of this disease.
Yes.
And look at the size of the caudate, even without measuring it.
Yeah.
I mean, you're having trouble even seeing the caudate.
Yeah.
It's this tiny little thing right here.
So you just narrowed the differential substantially, okay? Now, and I called the doctor, and what's the history? Well, there's a family history. Okay, so this is a familial problem.
So in terms of the diagnosis, I mean, it's pretty limited. Even though the patient does not have chorea, it's Huntington's chorea, and they frequently do not present with chorea. They frequently present with, behavioral and psychiatric disturbance. The chorea comes a little bit later. This is a very tough disease. It's found on chromosome 4. Not only can we identify it now with, you can send in your 23andMe kit for $100 and find out. Not only are you at risk for Huntington's disease, this is kind of depressing, but also by looking at the number of CAG repeats, cytosine, adenosine, and guanine, CAG repeats, you can tell what age the person is going to get Huntington's chorea at, which is also rather depressing. It's a disorder of polyglutamine toxicity. There are about 4 or 5 diseases that are like that have the same sort of toxicity pattern. I think 4 of the spinocerebellar degenerations have it too. The gene is called, just for interest, the IT15 gene, the interesting transcript gene. It's inherited as an autosomal dominant. This disease probably started out as a mutation in Scotland, because the incidence in Scotland is much higher than anywhere in the world, and it's likely that somebody from Scotland emigrated to Venezuela thereafter, because Venezuela has, by far and away, the second highest incidence of this disease. So it is a genetic disease. Unfortunately, it is autosomal dominant, and so there's a pretty good chance that the progeny are gonna get it.
Right. Now, as far as, is there any differential? Well, with the information that we have, that is family history, probably there's not. But if all you have is the image, how about like Wilson's, something like that? Because that will give you that'll affect the basal ganglia.
Right.
Unlikely, but that might be another thing you could think about, in inquiring about the history. And maybe a toxic metabolic could also affect it.
Sure, fair enough. And in Wilson's, they do get chorea.
Right.
People with Sydenham's chorea get they get unilateral putaminal increase in signal, but it usually comes on acutely. It's usually after a trauma. In fact, my own dad had it as a result of getting hit by a car. It went away. You can get it after rubella. It's been associated with HIV, infectious-induced chorea. For Wilson's disease, you're looking for a kind of a unique thalamic pattern of involvement, something called the big panda sign, where you may see some signal in the thalamus. We may talk about it a little bit later. So you're going to have signal alterations in a different distribution. It's not inherited as an autosomal dominant. Psychiatric disturbance is not the initial part of the disease in Wilson's disease. They get all kinds of other metabolic issues, including arthritis and renal disease, et cetera. So, that's something to consider, especially in a heredofamilial scenario. But I think the inheritance, all you got to do is make a phone call, and, autosomal dominant, 50% of the family members are going to have this.
Right.
There are a couple of other polyglutamine diseases. One of those is Kennedy syndrome, which is spinobulbar palsy. And then another one that, for those of you that are neuroradiologists, dentorubral pallidoleucine atrophy is another polyglutamine toxicity. So those are the polyglutamine diseases. They don't all have chorea, but 3 out of the 5 do have chorea. And probably Wilson's disease would have been one to consider without knowing anything else, although the imaging isn't consistent with that. Now, also in Wilson's disease, you can get iron deposition that's excessive, you can get copper deposition that's excessive, and you can get manganese toxicity or manganese deposition that's excessive. And each of them has different paramagnetic properties. So you're going to see some pretty weird high and low signals in the basal ganglia and thalamus. And you don't really get that paramagnetic phenomenon of either excessive low signal. The only excessive high signal you're going to see is high signal as the disease progresses in a very atrophic putamen, which this patient has subtle high signal in the putamen. I think the key is the history and the massive dilatation of the frontal horns.
But the point being, start thinking, when you see atrophy, meaning it's very easy to blow past this and just say central atrophy. And in that case, you will have done a disservice not only to this patient, but to his family. So when you start seeing that, I try to start categorizing in terms of distributions of things and try to give the clinician something to go on, okay? And this is a good case to kind of get you started on that thought process.
Now, one other point, if somebody does come in with chorea as a history, and you're resident or fellow or an attending, and, the first thing out of your head shouldn't be Huntington's chorea. Probably the first thing that comes in through the ER, first thing out of your brain should be drugs. Drugs are really, and I'm not talking like Reserpine, which we don't even use anymore. 2 categories of drugs, recreational drugs and antipsychotics. Those are going to be the main causes of acute chorea coming through the ER. Huntington's chorea, autosomal dominant, chromosome 4. Let's move on to the
Let's
next
hit
one.
546. All right, so another problem with cognitive function and awareness. So, this is the kind of history you get, right? I mean, very broad notion, but something, and they're thinking, they don't know what's going on. Does this guy have a tumor? Okay, so the thing we want to start doing, if we want to really help the clinicians, is start to think as they do. And when they ordered the scan, what I try to do is, okay, what was their differential when they ordered the scan? Okay, and I try to put a conclusion addressing each of those things that I thought they were thinking, meaning tumor, no tumor. Okay, that's one thing you're thinking. Is it a big subdural? No subdural. Okay, because those are all there. Because let me tell you, clinicians are suspicious. Okay, meaning if you don't address it specifically, they assume you didn't look. Okay, that's the world that we're in today. Because those guys are sitting in an exam room, clicking boxes, patients sitting right here, they're kind of, so our goal is, they don't have time to think, right? They're clicking, need boxes clicking, we're their brain trust, okay? But the way you build the credibility is to say, okay, I'm thinking just like you're thinking, I look for each of the things you were wondering about and address those. So a lot of my reports are pertinent negatives, okay? Because that's how they know, hey, some thought was given to this, okay? That's what they don't have enough time to do, but they want you to do. Okay, so here we have a case, and there is are some abnormalities here. And obviously, there's not going to be a big subdural. Okay. Now, one thing is, any of these dementia cases, one of the goals is, well, what's the diagnosis, prognosis, but also, is it one of those few instances that's treatable? Okay. So one thing I always address in these dementia cases is it NPH? That's one thing they're wondering. Okay. Because that at least is something you can do something about. We're going to talk about NPH later and when and where, but that's something you also would look at. So ventricular size, a little big, but there's no sulcal effacement. Okay, there's no transependymal spread. Okay, so I'll make that comment. Okay, address that concern. Okay, that they have. Okay, so they can move forward. So we have a pattern of atrophy, and so Alzheimer's, right, is one. We were talking about that. The temporal horns are critical, but also parietal. So this is not a parietal pattern. It's a frontotemporal pattern. Okay, so that's going to take us down another track.
So have a look. Pick a diagnosis. Obviously frontotemporal, favors one specific, and we said there are 5 major dementias that you ought to be thinking about, and I threw in Parkinson's, so maybe 6. But ALZ is typically going to be a temporoparietal disorder that affects the entorhinal cortex, which I showed you earlier. Frontal-lobar dementia is going to be, frontotemporal, usually spares the posterior 2/3 of the temporal horn, so-called knife blade atrophy. Let's see if we can show it. Let me scroll the sagittal here. And maybe it gets a little more than 1/3, but there is knife blade atrophy. It stops dead right there. So it fits really nicely, unfortunately, for Pick's disease. Parkinson's disease is only going to have this degree of atrophy very late. It's not going to be frontal predominant. LBD, Lewy body dementia, that really has a non-specific, I hate to use that word, a non-specific pattern of atrophy. The key to that diagnosis is the Parkinsonian clinical features and the visual and occasionally auditory hallucinations. So there you have to really use the clinical to assist you. And probably the 5th major one, which I failed to mention, we talked briefly about NPH, but that one is going to be maybe not pretty obvious, but obvious enough to consider. But vascular dementia is usually mixed in with a lot of these other dementias. And vascular dementia comes in many forms. We'll discuss it a little bit later in the vascular section. So this is Pick's disease, or formerly known as Pick's disease. Pick's disease is a group of disorders, fronto-lobar disorders, and it's now been broken down into several categories. One category, they have motor neuron disease, so it's called fronto-lobar dementia, MND. And then they break it down into the classic old Pick's disease, which is got these inclusions called ubiquitin positive inclusions. So that's frontotemporal dementia type U. And then you have the nonspecific type with no distinctive histology. Unfortunately, this disorder is carried on chromosome 17, and it has a pretty strong heredofamilial predilection. The inheritance varies among different groups, but probably somewhere in the order of 1/3 of cases, maybe as high as 40% are heredofamilial, whereas Alzheimer's disease, it's somewhere between 6 and 15%, and it's usually the ones that have early onset before age 55. So after age 55, the heredofamilial predilection of ALZ goes down quite a bit. Again, it's very frontally oriented. It likes the anterior portion of the temporal region. I like to look at this sagittal projection because look at what it's doing to Broca's area. I mean, it is just crushing Brodmann area 45 and 44. And earlier on in my career, I experienced in a relative this disorder called semantic aphasia with dementia. This woman who was my wife's aunt presented with aphasia. She couldn't really track the meaning of words, but everything else was fine. And all her studies were negative. Her MRI, her PET, everything. And then eventually she started developing atrophy of Broca's area. It took about 4 or 5 years for that to occur. And then this was labeled as left-sided Broca's area ALZ. We now know that it's more likely a variation of the Pick's family of diseases. So semantic aphasia with dementia is probably a variation of Pick's disease that likes Broca's area.
Let me just make a couple more points, because just for your dementia search pattern, right? So Dr. Pomerantz mentioned this. So here's your brain iron, here's your red nucleus, your zona compacta stripe, okay? So that's part of it. Now, we don't have the whole, we could look through a little better, but enough to say, could it be idiopathic Parkinson's? That can present with a dementia, okay? So probably not. The other thing is the midbrain volume, okay, for these multi-system atrophies, okay? So that's all part of your, you're going through and trying to categorize it and what's what. That's another pertinent negative, not Parkinson's, not multi-system atrophy, because Parkinson's has a treatment.
Or
right?
PSP. I mean, look how good it looks
right.
compared to the atrophy, which is massive, and the
right.
cerebellum looks great too.
Right, right. So we're going to see some examples of those things. But this, you want to develop, dementia. Develop your dementia search pattern. And the history is really helpful in these dementias, okay? Because, for example, in this frontopolar, you're going to get 2 histories. One is the one Dr. Pomerantz just said. A semantic dementia, okay, is one of the 2 syndromes. The other one is a behavioral disinhibition. These people are starting to act weird. They're starting to do things in public that you might not want them to do, okay? So you can start categorizing that and fit that in. Now, the other one would be hallucinations, okay? Visual hallucinations, think Lewy body, because Lewy body has a less specific anatomic pattern. So Parkinsonian with hallucinations, okay, but maybe a less specific anatomic pattern. Before you even get to the images, you already are narrowing your differential, okay? So really look at these histories, and if you have access to the clinician, it can help you out. This one, the imaging is very strong, so we have a good idea, and, the callosum is thin, So try to anatomically parse out these things and having a good dementia search pattern and getting the most out of the history that you do have.
And now probably you could add a third sort of category, motor neuron disease, to the actual presenting syndrome, because that throws you off quite a bit. When you think motor neuron disease, nobody ever thinks Pick's disease, these days. But that is one of the 3 big syndromes. This is one of the tauopathies. So if you get back a path report that there was tau present in the neuropath report upon death, the reason it's relevant is if it's Pick's disease, right, it's 40% or 30% heredofamilial. The patient's 70 years old and it's ALZ, it's 6 to 15% heredofamilial, very low. So it's going to matter to the family, and PSP and progressive supranuclear palsy and corticobasal degeneration, which we'll discuss if we have time. It affects the cortex and the basal ganglia. It's sort of a Parkinsonian-like weird disease. The patients usually die in 6 to 7 years. Those are the 4 major tauopathies. And for you neuroradiology, neuroimaging, and neuroclinician fans out there, that's probably one you might want to know. Really nasty example of Pick's disease. I don't know if the patient was aphasic, but my guess is...
This was more behavioral, at least the history that we had.
Yeah, the disinhibition, dysexecutive syndrome, we've all seen that in public. And so if you see somebody up there in public behaving badly, saying things that you think should never be said in public, you might want to think about, the possibility of some type of dysexecutive syndrome. Shall we move on?
Yeah.
I'll load.
Gait disturbance.
Gait disturbance. I'm going to throw up the sagittal just so they can have a look at the brainstem, and they have their own. And maybe a coronal, Dr. Schupek, to look at the entorhinal cortex?
Right,
maybe?
that's part of your... Now, entorhinal cortex, Dr. Pomerantz mentioned that a couple times. What's the entorhinal cortex? Well, basically, the entorhinal cortex, you find the collateral sulcus right here, and everything medial to that. When people talk about the entorhinal cortex, that's what they're talking about. So the hippocampal formation, the anterior portion of it.
Yeah, here's the collateral sulcus for you young'uns, and then here is the entorhinal cortex. And then there are all kinds of interesting structures which we don't have time to hit, but you can get them online. The subiculum, the dentate gyrus, the amygdala. There's about the hippocampal gyrus. And by the way, the hippocampus, which is more posterior, is spared in Pick's disease. That's a pretty important point. Or just simply remembering that Pick's disease likes the anterior third to 2/3 of the temporal lobe, and it almost always spares the back third of the temporal lobe. So that's helpful, as we saw in the sagittal projection. We've got a coronal flare-up on the far right. I'm going to make it bigger while you guys are scrolling. We've got an axial flare in the middle and a sagittal T1 just to see what's going on with the cerebellum, the colliculus, the mammillary body. Well, it looks a little small maybe.
Right. So, this is an elderly patient, okay? So the problem with an elderly patient is they're going to have more than one thing, okay? Meaning you're going to have a few things to sort out, right? Meaning, so there's a bunch of vascular disease, right? So is that the problem? Or is there anything else going on here, okay? Because you could report this out and say, wow, cerebral vascular disease, couple of infarcts, I guess that's the problem.
So in terms of discussing this pattern of vascular gliosis, so to speak, we've got mostly periventricular gliosis, but we've also got some patchy, but not subcortical gliosis. Some of it's confluent. And the way I usually deal with this is I describe it. If it's not temporally avid, if it doesn't like the temporooccipital region, as in MS, patients in the wrong age group, they don't have signs of MS. I don't put MS in my discussion. I never say can't rule out and then go through this long liturgy of white matter disorders. That's crazy. First of all, white matter disease like this doesn't occur in Japanese men. Or it occurs very sparsely in Japanese men, and it's because of their diet. So to call it normal is something I kind of cringe at. But in the United States and Canada, we consider 1 per decade okay. And it's probably because of how we live. So I don't get too excited if it's not more than 1 per decade and they're not inordinately large. Now in a case like this, I would say something like moderate, and granted it is subjective, or moderate to severe, peri and non-periventricular gliosis, for which the differential diagnosis includes hypertension and other causes of small vessel arteriopathy and/or venopathy, such as hypercholesterolemia, hypertriglyceridemia, and other risk factors for premature or severe arteriosclerosis. What are those things? Smoking, diabetes, all the things that you know. There are some other weird ones in there too. Hypercoagulable states. And in younger individuals, I'll start getting into a much more in-depth differential diagnosis. And, if somebody is demented, of course, you would have to consider the various forms of vascular dementia related to hypertension or multi-infarct dementia, where you see multiple wedge-shaped infarcts, multiple lacunar infarcts, and you don't have another good explanation. Now, 15% of the time, a major neurodegenerative disease coexists with vascular disease as the cause of the cognitive decline, as reported in the journal Pathology about 20 years ago. But that's how I handled, these vascular signals. I would not mention MS in a 70-year-old with that clinical history and with this pattern. It's not a good pattern for MS. It's not right angle demyelination, and it's pretty confluent, and it's not temporal.
Right. Now, so we got vascular disease, but is that the whole problem? So the ventricles are big, but is it NPH? I don't think so, right? There's no sulcal effacement. There's no transependymal spread, okay? So that's some of the things we can answer. I mean, you got temporal pattern atrophy for sure, probably. Although the hippocampi are not that bad, right? So we're kind of working on, here's our brain iron, okay? So next thing we're looking at is the midbrain. Now this midbrain looks a little bit different than the last midbrain we saw, that kind of chubby thing. This one's a little bit beaked right here. Okay? See how flattened that is? Sort of looks like a bird.
Like a hummingbird.
And the top of the head, okay, the collicular plate or the kind of crest there, also kind of a little skinny. Okay? So what this patient had is progressive supranuclear palsy. Okay? So we're going to start getting into these neurodegenerative things. So you got to think a little bit about what are these syndromes. Okay? So here's a gait disturbance, right? Well, where do you see a gait disturbance? And the next thing is, well, what kind of gait disturbance, right? Does it mean the guy's like flopping all over the place? So if you're talking about a Parkinson's type syndrome, they have a specific type of gait disturbance. They have a so-called festinating gait, tiny little steps. You're kind of walking around like this, okay? Tremors, right? You're going to hear history of tremor. Well, what kind of tremor? Is it a resting tremor? Is it an intention tremor? Different diseases, okay? So that's the kind of thing we're going to want. So this patient had a gait disturbance, has a neurodegenerative condition, okay?
They do get rigidity and dystonia, but they don't get tremor.
Right.
Tremor's not a big part of PSP, which is a
Right.
really helpful thing. So you got to kind of got to
Right.
think like a clinician.
So a PSP patient is going to be somebody who has a Parkinsonian presentation with some difference, but with eye findings, vertical gaze palsy, okay? I just remember a patient that I had when I was on neurology as a resident, and he would read his newspaper sideways, okay? And I always remembered it after that. Okay, so a Parkinson's with, if you hear something, a patient has Parkinson's disease with gaze palsy, you start thinking, well, maybe it's not Parkinson's. Okay, because really important differential, that is these kind of multi-system atrophies versus idiopathic Parkinson's, the medicines that they're on might not be working, right? Because they're treating the wrong disease, okay, and actually could be made worse by these medicines. So a very important differential to distinguish between actual Parkinson's, which may respond to medications, or one of these other syndromes that have a Parkinsonian presentation, but are not Parkinson's, and actually they're not going to be helped or made worse by these medicines. Okay, very important differential. Prognosis also differs, okay? So once again, it's all this kind of dementia search pattern that we're trying to build up here, okay? So you want to make sure you don't miss any of the steps, because as I say, you could have got stopped at vascular disease. You have next case, old guy, bunch of strokes, okay, but actually the clinician had really helped us out here by giving us some information, and so he's like a lot of people, 40-some% are going to have a neurodegenerative and superimposed vascular. In this age group, a lot of them are going to have some vascular for sure, okay? But we don't want to miss steps in our thing and kind of get off the wrong track and miss a potentially important diagnosis.
And I blew up the collicular plate for you. I mean, look at the difference between the inferior colliculus. Granted, this is a hard diagnosis to make proactively without a little history, but look at the superior colliculus. It's really dramatic when you blow it up, and it does look a little bit like a hummingbird. They do get involvement of a couple of other areas. They'll get involvement of the globus pallidus, and I don't think I can really appreciate that here. Another thing they get is they get kind of smearing down low in the subthalamic nucleus. This patient does have that, and unless you're really dialed into it, that would be a hard finding to make. And they do get, loss of iron in the midbrain, not in the same pattern of Parkinson's, which is kind of like from the side inward, but they get general loss of GABAergic function. So they do have some Parkinsonian features, but I think an important aspect of it is they don't have tremor as a prominent aspect of their chief complaint, right, even though they do have movement disorder.
Okay, just for a little anatomy. So here's your third nerves, right? Interpedunculaire
Make them a little
fossa.
brighter for you, and then I'll let you.
So, start kind of putting your anatomy together. You'll see it. Sometimes it's hard to see that one. You got a good one. Third nerves here. Interpeduncular fossa. But the midbrain is just a little skinny, little, not a big chubby one like we saw in the last case. We'll see what it looks like here. So you got to have to, sort of get these implanted in your mind, and say, wait a second, going through your axials, then you start looking at the sagittal. So Dr. Pomerantz mentioned the sagittal is really important when you're, the coronal is important, to look at the hippocampine and entorhinal cortices. Sagittal is important for all these midbrain kind of multi-system atrophy things, and then the midbrain iron.
I have to be intellectually honest. In the younger and mid phase of my career, I wouldn't have appreciated that this was atrophic without the sagittal. But one finding I find helpful now that I'm a little bit older is this widening, the splaying of the intrapeduncular cistern and the axial projection, because a lot of us gravitate to the axial from our prior experience in CT. We kind of shy away from the projections that we didn't grow up on. Now a lot of you are trained in sagittal, so you younger radiologists are more comfortable with it. But this widening of this angle, the so-called crural angle, is another sign of midbrain atrophy. And the patient does have brain iron, substantia nigra and red nucleus. It's present. But the key is the sagittal. Shall we move on?
Okay.
Remember, this is one of the tauopathies, too, that we discussed earlier. Fixed disease tauopathy, Alzheimer's disease tauopathy, PSP, corticobasal degeneration.
All right.
All right, so I'm putting up a sagittal, as I usually do. This time I've got a sagittal flare, which I have magnified in deference to Alex. And I think I'm going to get rid of my axial T1. I'll put up my axial flare. And I've got an axial T2. I'll scroll these together. I'm not going to go too far off the midline on the sagittal. This is pulsation anteriorly for those of you that are wondering, and hopefully you're scrolling your own. This is a very complicated case, so take a little bit of time, and I would look at all the images. Make sure you look at the coronal. I'm going to pull down the coronal, and I'm going to check out the entorhinal cortex because there's some serious atrophy here. So here's your choroidal fissure right here, and that one's pretty juicy, this entorhinal cortex. That one's not bad either. And I'm looking for things like choroidal fissure dilatation. How big are the temporal horns? The answer is they're a little dilated, but not nearly.
Yes,
Not nearly commensurate with the rest of the atrophy that's present in this case. I mean, this is a wiener dog little brainstem right here, isn't it?
Right.
Cerebellum is atrophic. And I mean, look at that corpus callosum. That is really weird. It's got some high signal throughout. I mean, it involves the body and the splenium especially. Probably comes down into the lamina terminalis. The fornix is crushed. Look at that poor fornix. And this time we don't have atrophy of the superior colliculus. It may be flattened out a little bit, or if we do, it's very mild, not nearly to the degree that we saw previously. There's the posterior commissure and habenular area here. Can't separate them out that well. Pineal gland. I'll demagnify for a minute. The cerebellum is involved. A lot of places, a lot of anatomic areas are involved. I mean, look at the brachium conjunctivum, the superior cerebellar peduncle. Let's check out the middle. That's atrophic, the middle cerebellar peduncle. How about the restiform body? Wow, look at that. Looks stretched out. Not as small as the rest. The olive is flat. The olivary sulcus is a little shallow. The cerebellum, the vermis, and the hemispheres are involved. So we could do an anatomic treatise on this case. And the entire cortex is atrophic, isn't it? So there's no way this could be NPH with gyri and sulci this big, because that often comes up in almost every case. So I'd like you to think about the differential diagnosis that you would generate. And Alzheimer's wouldn't be in there. So you've already eliminated an important one, Pick's disease, or what should now be called fronto-lobar temporal dementia. That really shouldn't be in there. Let's take a look at the temporal lobe. I mean, it's going to be atrophic, but does it have that knife blade pattern of atrophy? Well, maybe a little bit. Maybe it does. It does. So, but it certainly doesn't have, it doesn't explain this corpus callosum. And it doesn't explain the brainstem and posterior fossa atrophy. Remember our frontal lobar dementia, how decent the posterior fossa looked. So that takes us out of that diagnosis. Corticobasal degeneration, that's a tough diagnosis. It is a very basal ganglia-oriented differential with Parkinsonian features, and that's another tauopathy. So that would be the differential, but it's very rare. How about Lewy body dementia? Visual and auditory hallucinations. It can kind of look like anything, but it doesn't have this callosal-centric posterior fossa component. I mean, that really takes you out of LBD. So we've taken you out of LBD, NPH, ALZ, and frontal-lobar dementia, or FLD, or FLTD. So we've really eliminated a lot, and we've also eliminated vascular dementia. So now we've got a, there is some white matter disease, but not enough to cause, a really severe cognitive decline, and not enough to cause this kind of atrophy. So now we're into something else. And PSP we've already shown, so it's highly unlikely to be that. Plus we don't have the collicular findings, although we do have a hummingbird. We've got a hummingbird right there. In fact, we've got such a good hummingbird we could put a feeder out there.
Okay.
All right. What's the answer, Dr. Schupek?
All right, well, so a lot of findings. So, once again, elderly patient, so there's going to have all these things going on, some vascular, there's going to be some atrophy, okay? But so the pattern and also the predominant pattern, meaning this thing might be but where's the predominant pattern of atrophy? And also this one kind of has an interesting finding because I put it on there. See this view right here? This Series 7, Image 10. See, there's a line here on the pontine median raphe and one going across. This is the hot cross bun sign, okay? So this person had a multi-system atrophy. So we've been talking about that, right? PSP, okay, all these alternatives, these neurodegenerative things. Now, remember I was talking about the tremor, right? Somebody says, well, tremor. Okay, well, what kind of tremor? Because there are a couple of categories of the multi-system atrophies. There's an MSAC that presents with a cerebellar tremor. Okay, what's a cerebellar tremor? You guys remember from medical school, that is your intention tremor. That is, you put your finger up, the guy goes like this, okay? Then the alternative tremor is a resting tremor, you're pill rolling. Okay, so that's your Parkinsonian tremor. Okay, so you can get MSAs of two types, MSA-C, which is predominantly cerebellar, okay? And you might see predominantly cerebellar atrophy, or MSAP, which is Parkinsonian, where it's mostly sort of extrapyramidal, okay?
And now they call that striatonigral degeneration. They
Right.
lump that in there with MSAP.
Right. And so, but looking for these signs and look for the predominance, where is the atrophy, will allow you to kind of prioritize. Yeah, there's vascular disease, but I don't think that's the problem. Vascular disease is not going to give you this pattern of atrophy, okay, and try to categorize it and say, depending on the history you get, it can kind of help yourself along in trying to getting in the right track. But this one, you can see this is wide open. I mean, it's not quite a molar tooth like you would see, but it kind of looks like that, like in Joubert's syndrome, okay? Molar tooth atrophy, it starts to look like that, okay? All
And
right.
you can get a hot cross bun sign, by the way. One of the other important causes of a hot cross bun sign is CJD.
Right.
Creutzfeldt-Jakob disease, prion-mediated disease. You can also see it in some spinocerebellar degenerations, and it's also been described in various vasculitides. But if you're going to get it on a board exam, it's going to be associated with MSA. There's also an MSA-A, an autonomic type, and that's also known to many of you as Shy-Drager syndrome.
Right.
So the hot cross bun sign, not specific for MSA, but characteristically associated with it.
Right.
The big other one to remember there, especially when you get these weird areas of high signal, that don't enhance in other parts of the brain, cortex, weird spots that just don't go away, but yet it's not an infarct, you got to think about prion-mediated disease as a cause of dementia.
Okay, let's just talk about peduncles for a second. Dr. Pomerantz, the restiform body, okay, inferior cerebellar peduncle, that's atrophic. And look at the middle cerebellar peduncle, and that's where this hot cross bun sign comes from atrophy of these fibers of the middle cerebellar peduncle, okay? And this is your brachium conjunctivum, right? Superior cerebellar peduncle, okay? So you got to start looking at those structures and get yourself kind of organized anatomically. You know, the aqueduct is big.
Okay. I mean, this is a horrible disease. It took the life of one of my closest associates' father, and you know, they get all kinds of weird movement disorders. They get myoclonus. They get involvement of what's called the Guillain-Molleret triangle, which is kind of the myoclonus triangle, which includes the inferior olive, the dentate nucleus. What's the third part of the triangle? Does anybody remember? It's actually the red nucleus.
Right.
Red nucleus, yes. So red nucleus, dentate, and olive. So let's take a look at the red nucleus in this one. Pretty small. There it is right there. Small but present.
Right.
And as I said earlier, the inferior olive is almost non-existent, right? The olivary protuberance is flat. The olivary sulcus is non-existent. Right. So involvement of that triangle, not pathognomonic, but characteristically seen with this disease. And the myoclonus is horrible.
Okay, and the zona compacta stripe, okay, so if we're thinking Parkinson's is part of our, is intact.
Let's blow that up a little bit so they can see a little better. So the separation between
Right.
the red nucleus and the substantia nigra, this
Right.
whiter, brighter area, should be intervening between the two. They shouldn't bleed together.
Right.
And they would in end-stage Parkinson's like this, and they don't.
And here's your nigrosome. We'll talk about that in a future case.
Yeah, there is some loss of iron here, but still, I think it's very important that you have this preserved area between the two to disqualify Parkinson's disease, which, by the way, end-stage Parkinson's disease is the fifth and final cause described in literature for the hot cross bun sign. But that's in the end game.